You will now be placed into the conference. You are now muted. This conference is now being recorded.
Welcome to the Society of Surgical Oncology webinar, DCIS. For today's program, the moderator is Dr. Mary Gemignani. The invited discussant is Dr. Hiram Cody, and the case presentations will be conducted by Dr. Julie Dunderdale and Dr. Megan Hansen. Audiocast quality is subject to your equipment, available bandwidth, and internet traffic. If you experience unsatisfactory audio quality, please use the telephone dial-in option provided in your confirmation and reminder emails. If you have dialed in, operator assistance is available by pressing #. You can send questions at any time by using the chat window located to the left of the presentation screen. A question and answer session will follow each presentation. Please press #, when your name is called upon by one of the speakers. I will now turn the call over to Dr. Mary Gemignani. Please begin.
Yes, hello everyone. Welcome to the fourth SSO webinar. Today's topic is going to be DCIS. I'm currently the Fellowship Director at Memorial Sloan Kettering Cancer Center, and I'm very happy to have Dr. Cody be our expert discussant on DCIS. He's also, as you probably are all aware, at Memorial Sloan Kettering Cancer Center. So on behalf of the SSO, Anna Olivares is here, who's been instrumental in helping us develop these webinars and helping with the platform. And we also have a platform operator that you have just heard speak. So these webinars were created for SSO fellows as the main purpose is to discuss topics in breast cancer where there are current controversies and differences in treatment options, as well as variations in delivery of care. So this is a national forum of all SSO fellows, and so we hope to highlight not only standard treatments, but also where controversies exist. So this evening, this is going to be about 45 minutes to an hour, and we have two presentations this evening that are meant to be interactive. So what I'm going to do as the moderator of this session is during the presentations, I will ask some questions. And so we will pause at the end of each slide, not very much, but we can do that. After this presentations, the slide presentations, Dr. Cody will go ahead and do a discussion, and then there'll be a question and answer session before the next presentation. So without any further ado, I'd like to go ahead and have Julie Dunderdale of Northwestern Memorial Hospital go ahead and start the first presentation. Thank you, Julie, for doing this for us.
Okay. All right. So to start, so the first case is a 32-year-old woman who was found to have what was thought to be a right breast mass that was detected by her OBGYN. As far as her other medical history, it's really remarkable. She has no medical problems, no allergies, not currently taking any medications. As far as her GYN history, she had menarche at age 13. She's been pregnant once, has one child. First live birth was at 31. She did breastfeed for about 8 months. She has a history of using OCPs but stopped in 2013. As far as her family medical history that's significant, she had a mother that was diagnosed with breast cancer at age 50. She underwent genetic testing. It was BRCA negative. She also had a maternal aunt that it wasn't quite clear. She had breast and possibly ovarian and uterine cancer, first diagnosed at age 40. The patient was unaware of her genetic testing. As far as her social history, she does not smoke or use any tobacco products. She did have social alcohol use. When we saw her in clinic on physical exam, she was noted to have a larger breast size. Bra size was double F. On the right breast, where the OBGYN thought she felt a mass, there was some dense fibrogranule tissue, but there was no distinct mass. This was in her inner upper breast. As far as her lymph nodes, they were also negative on exam. So next she was sent for some diagnostic imaging. You can see her mammogram here. There was an area of calcifications that they were concerned about. She also went for an ultrasound where they saw some distortion in her breast. So her imaging showed a 5.7 centimeter span of pleomorphic microcalcifications in the upper inner right breast that was highly suspicious, and there was an ultrasound correlate that we saw at 138 centimeters from the nipple. So as a result, she was sent for an ultrasound guided core needle biopsy. This was done and it came back as DCIS grade 3. There was some focal microinvasion. It was ER/PR negative. You can see one of the slides here from her core biopsy that shows the DCIS all here. And if we advance, we have some more slides showing the DCIS, and then you can see small areas of microinvasion. Because she was of younger age, premenopausal status, and had dense breast, it was recommended that she undergo an MRI to evaluate for the extent of disease and rule out a contralateral breast cancer. This is her MRI below. As you can see, she has some segmental clumped non-mass enhancement. It was about 5.6 centimeters in the same area, 130 right breast, that corresponded to her biopsy-proven DCIS. She did not have any evidence of malignancy in her left breast.
So, Julie, do you routinely get MRIs for DCIS?
Not for DCIS. So our radiologists here and breast surgeons have come up with some guidelines. So one of them is premenopausal status, especially if they have dense breast with a new diagnosis of cancer.
What do you feel is the sensitivity of breast MRI in detection of pure DCIS?
Ooh, I don't know.
Do you think it's high or low?
For the DCIS, I don't think it would have shown us much more than what we already had known from our other imaging. Since she had a wide area of calcifications, I don't suspect we would find anything different based on MRI.
Yeah, so initially most of the data did show that sensitivity for pure DCIS is usually around 80%, but with more modern studies, especially if you're looking at these high-risk lesions, especially the microinvasive lesions, the percentages are much higher. So, and most of these do present like what you're showing as non-clumped, non-mass clumped enhancement. So, not routinely necessary, but can be helpful in some cases.
Okay.
So, yeah.
All right. So then I went on to discuss surgery with her prior to discussing which procedure, because she was younger and she did have the family history. We did refer her for genetic counseling. She ended up getting genetic testing. She got the BRCA testing, which was negative. As a result, the patient opted for breast conservation since she was of a larger breast size. We discussed with her that this would be possible, and in the future she may consider reduction on the other side to match. So she underwent a bracketed lumpectomy. We also decided to do the sentinel lymph node biopsy because she did have areas of microinvasion. So that was done all at the time of surgery.
Can you talk a little bit, Julie, can you talk a little bit about how at your institution you handle margins? Here at Memorial we do cavity shave margins all the way around. It looks like you bracket it, so is it mostly just one specimen that is done?
No, we do shave margins too. So we bracketed it just because it was such a wide area of calcifications. They wanted to make sure we got the entire area, so they were bracketing the calcifications for us there. But we still do shave margins on all of our cancer patients. So she also had shave margins.
And so when you talked to this patient, what did you quote her as her risk of local recurrence with breast-conserving surgery and radiation, looking at, one of the papers that we included in the package, the NSABP B17 data? What would you have given her as a possibility of local recurrence?
Ooh, her local recurrence, sorry. I can't remember what we quoted of her because it was a little higher because she has the microinvasion with the ER/PR negative in grade 3. Sorry, I don't have a percentage for you.
Okay, so we should just briefly maybe call on a lifeline here. So I'm just going to go ahead and pick a Kiko Chiba from the Mayo. What do you think? If you're on the line, if you could unmute your mic. Okay. So we'll try one more and then we'll move on. So Jennifer Saldana, Cleveland Clinic, local recurrence with breast conserving surgery. I'm going to go ahead and call on our lifeline here for Memorial, one of our fellows.
Hello?
Yeah, hi.
Mm-hmm. I knew the answer. Hello?
Yes, who's this?
This is Jennifer.
Hi, Jennifer. Do you want to go ahead and give us what you think her local recurrence rate would be?
After the NSABP 17, it was detected that there was a 60% lower risk of the same side tumor recurrence with the addition of radiation therapy.
Mm-hmm. That's good. So what would you give a ballpark? 10, 15 years local recurrence with radiation?
I would say less than 10 to 15%.
Okay. It's a little bit lower in the NSABP study, but I think that's a good ballpark. It was 8.9% with the addition of radiation, but I think that's a good ballpark to consider. She's ER negative, so she won't be taking tamoxifen. Okay, great. Julie, go ahead.
Okay, so she underwent surgery, and then we just have her pathology from surgery. So again, it was grade 3 DCIS with multiple foci of microinvasion. She was ER negative, PR negative as before. All her margins were negative. She had 2 lymph nodes that were negative for carcinoma. You can just see from her surgery there. That's her DCIS, and then some more images that show her extensive DCIS.
How often do you do sentinel lymph node biopsy and DCIS?
So at our institution, so some of our surgeons differ. For the most part, we only do it if there's concern for microevasion. One of our surgeons does it if it is a large area of grade 3 DCIS. He usually recommends it.
And do you do it with mastectomy, lumpectomies, or?
Oh, sorry, for lumpectomy. So for mastectomy, everybody gets if they have DCIS, I guess, and a lymph node biopsy.
Okay.
All right, and then, okay, so for after that, she was referred to our radiation oncologist, and they discussed with her radiation with the standard fraction and a boost.
Great. So that was a really good presentation. I'm going to go ahead and turn it over to Dr. Cody for a discussion of this case.
Well, this is an interesting patient and raises a number of interesting questions for us. I think the way she was worked up was perfect. You got a pretty good sense of the extent of the lesion based on the mammogram. The MRI confirmed it. We didn't have any false positives. We always hold our breath on that one, but here it looked as if we have a concordance between the MRI and the mammography. So I think doing mammographically guided bracketing of this was clearly the way to go. This was in the medial aspect of the breast, it appears, on the MRI. So one question in a patient with a very large breast would be, would you ever consider an oncoplastic approach here? My experience is that most patients with a very large breast who wanted reduction would have already had it. So particularly for a large DCIS, I wouldn't be enthused about doing an oncoplastic approach here, only because you might have difficulty in the event that you got a positive margin, or if you found unexpectedly extensive disease requiring mastectomy, you'd now be dealing with a reduction type incision where I think the morbidity of a mastectomy with immediate reconstruction and poor wound healing would be more frequent. The microinvasion is an interesting wrinkle. We find that in recent years our pathologists are having a little diagnosis creep, and my sense is we're seeing more microinvasion than we ever saw historically. The question is, does microinvasion really require us to do a sentinel node? This is something I think we've all done. Historically, we've taken a closer look at this, and what we've found is the rate of clinically significant axillary node metastases, i.e. H&E detected, is only about 1%. Most of what you pick up on a sentinel node biopsy with DCIS and microinvasion is IHC detected metastases, which we now think aren't clinically significant. So we're really seeing a yield of sentinel node biopsy for microinvasion about the same as it is for DCIS, and I think it really is worth questioning whether these patients need a sentinel node biopsy. Many of us are still doing it, but I think this is something where we may become a little more conservative over time, because sentinel node, of course, does have some morbidity. I think this is clearly a patient that needs radiation. I don't think there's any debate about that at all. I typically quote these patients about a 1% per year risk of local recurrence. So at 10 years, 10%, at 15 years, 15%. I think it's particularly important that patients realize that local recurrence of DCIS is linear. It's not only in the first 5 years, but it's a slow, steady rate over at least 15 years. I've made a chart for myself that I keep on the wall in the clinic. One is the chart of the long-term results of B17 and B24, just emphasizing that even though the local recurrences pile up, you don't really see an effect on breast cancer-specific mortality. And I think it's always good to remind ourselves that DCIS is not a lethal disease. We've had trouble showing that patients with microinvasion do any worse than patients with DCIS. And in our microinvasion study of about 100 patients, at 6 years follow-up, we didn't have any breast cancer mortalities. I'm sure we would have some if we followed them long enough. But again, DCIS with microinvasion probably behaves a lot like plain old DCIS. And this is something I think needs confirmation on a wider basis. So my injunction to all of you when you go out there is this would be a nice clinical project going forward, keeping track of your microinvasive patients and seeing if we really need to be as assiduous about sentinel node biopsy as we've been historically.
So Dr. Cody, can you talk a little bit about observation for patients with high-grade DCIS? So thinking about the study from the ECOG group looking at 5194, where they picked the patients and just watched them, and they stratified between the low grades and the high grades because these are significantly different and one of the primary reasons why we use radiation.
Yeah. It's an interesting study. We're not comfortable with observing DCIS based on our own institutional experience. You may know we just presented at the SSO a series of patients who had core biopsy diagnosis of DCIS and met criteria for observation in the European observation trial. And what we found was that 20% of those patients had enough disease that they would have required a sentinel node biopsy or a significant change in their treatment. So we're not yet comfortable with observation as standard care. I think this really belongs in clinical trials, and I'll be very interested going forward to see what we find. But at least from our perspective, we are not comfortable with observing DCIS as our standard approach.
Great. So I'd like to go ahead for the next couple of minutes and open up for any questions from the fellows to us. So if you go ahead, you can either do it as a chat, which the operator can certainly help me with, or you can unmute your mic and ask us questions. Okay. Give it just one more minute.
Oh, yeah, Jean is typing from. Yeah.
Okay, so we have a question from LaShandra asking, what about those patients that are ER negative? Would you give them a higher risk of recurrence as compared to the majority of patients who are ER positive, as in seen in the majority of patients with DCIS? Dr. Cody?
Well, the other table that I've made for myself from the DCIS data is Craig Allred's study. This was first presented at ASCO in about 2002 and has the world's record for longest delay to publication. I think it took more than 10 years to actually be published in JCO. But what they showed was that ER status, the benefit of tamoxifen treatment was related to ER status. Tamoxifen significantly reduced local recurrence in the ER positive patients. It didn't have a benefit in the ER negative patients. And I'm not sure that there was much of a difference in the rate of local recurrence between ER negative and ER positive. Mary, what's your take on that?
Yeah, I would say that there's not a big significant difference.
I think it's about the same. Unlike for invasive cancer, where of course we see a higher early event rate with ER negative, I'm not aware of a comparable difference in DCIS.
So we have another question coming in from Amelia. So would anyone consider separating the segmental mastectomy and stage oncoplastic reductions to assure negative margins? I'll go ahead and answer that first. I think that if the area is significant with microcalcifications and you're concerned that the resection isn't going to allow for complete margin assessment or complete resection of the entire area, where you're sort of pushing the envelopes of oncoplastic surgery, I think it's reasonable to do it as a staged operation, and the patients are usually fine with that when you explain that going back for the margin is going to be difficult. Obviously, it depends on what kind of oncoplastic procedure you're doing and how big the breast is and how much you're taking out. So in some cases, yes, it's reasonable to do together, and in some cases, no. Dr. Cody?
Yeah, I agree completely. I think with an extensive lesion like this, if you were planning oncoplastic, do it absolutely as a staged procedure. Do it in close collaboration with the plastic surgeon. You don't want to bag the vascular pedicle to the nipple areola complex. And in extensive DCIS, I think the way we operate as oncologic surgeons, we're not as attentive to this as the plastic surgeons are. And several of these I've done jointly with the plastic surgeon, with me aiming to do my normal resection and the plastic surgeon holding my hand back for fear that we'd devascularize the nipple. So I think the key technical point in doing a staged operation is that you do it in such a way that you preserve a good pedicle for the nipple. It doesn't have to be an inferior pedicle. That pedicle can come from any direction, but do this in collaboration with your plastic surgeon.
Great, thank you. And one more question on this topic before, I think we probably have enough time for one or two, but before we move on to this next case. So Jean is asking, what are your criteria for doing sentinel lymph node biopsy at the same time as lumpectomy for DCIS? So here at Memorial, unless there's microinvasion, it depends obviously on the patient's age and what the assessment is for the lumpectomy, but we do the sentinel lymph node biopsy at the time of lumpectomy for microinvasive. Otherwise, we don't do it. With mastectomies, we usually do it in most case scenarios.
I think there's one setting in which you might do it, and that's the lesions that present as a mass, clinically or on mammo or on sono. This was an interesting case in that the sono showed a peculiar-looking mass, which I think was related to the DCIS, but it didn't seem to be as extensive as what you could see on the mammo. So I think this is a good one to discuss with the radiologist up front and get their take on the significance of the mass. It seems as if what was originally palpated by the GYN didn't correspond with what ended up being the DCIS on imaging.
So Julie, question for you. Did what was the OBGYN palpated corresponded to the area of malignancy, DCIS?
No, she actually palpated an area that was closer to the nipple. This was farther out from the nipple where it actually turned out to be. So it was just kind of lucky that they thought there was something there, and she ended up getting a workup, and they found this incidentally.
Lots of the literature on this topic says that you should do sentinel nodes for high-grade DCIS. And I don't think high-grade by itself is an indication for sentinel node at all. I think really that we've discussed the significant ones, the extent of the lesion, the presence of a mass, microinvasion, but as I told you, I'm questioning microinvasion these days.
Mm-hmm. And so last question on this topic is the quote, Dr. Cody, is the quote of 1% per year of local recurrence for DCIS, assuming the patient will receive radiation and tamoxifen?
It certainly is assuming radiation. Tamoxifen gives you another few percent reduction in the rate of local recurrence, but the reduction is much greater with radiation. You have to be a little careful in this literature because a lot of it is stating proportional risk reduction. The figures your patients want to hear are absolute risk reduction. So always try to quote an absolute number. Proportional reduction makes the effect sound greater than it is in absolute terms.
Okay, and then one more question from us. Amy, are you on Mike John Wayne Cancer Institute? So I'll go ahead and ask the question, and then anyone else who can have access to the mic who wants to come up, or our fellows can certainly answer it. So what would you tell this patient, according to evidence-based studies, of her contralateral breast cancer risk for the time period in the NSABP B17 study?
Dr. Geminani, I'm here.
Hi, what do you think?
Hi.
What would you tell her?
Her risk of contralateral breast cancer.
She's BRCA negative.
BRCA negative, ER, so not on tamoxifen.
Right.
I would say it's probably not too dissimilar from the risk of 1% per year, but maybe a little bit less as far as breast recurrence.
20%. Yeah, so the 15-year follow-up study, and also in the NSABP, the B24 trial, showed it to be about 10%. And so the latest update on the 15-year study from the B17 trial did the contralateral risk at 10%. If you look at the B24 with taking tamoxifen, it's a little lower than that, but I think that's a reasonable answer. Thank you.
Dr. Geminani, one more question. All of these rates that we're talking about are more applicable for middle-aged women, and this lady was 30. Is that right, Julie? 32. So would you quote her a little bit higher rates than what we would quote out of these historic studies?
I think you have to be careful in the data that we have, because most of the patients that were entered into these trials were older. But yes, intuitively we would say, whereas the 1% per year that Dr. Cody uses actually helps to give them a longer-term perspective of what their risk is. But yeah, so there are very few patients in these older studies that were in their 30s.
And if you look at the literature on DCIS, age is a very significant risk factor for ipsilateral breast tumor recurrence. Patricia Cronin, do you want to say something about that?
Well, again, this was another paper that was presented at the SSO with regards to the impact of age on recurrence. And certainly from our data, I would certainly say that her risk at the age of 32 would be much higher than what we would quote from NSABP. And that paper should be published, has been accepted for publication and should be out shortly. Mm-hmm. And I do think it will change how we perceive risk in regards to recurrence dependent on age.
And Patricia, how big a study was that?
So that was just almost 3,000 patients, mm-hmm. Of which 141 were under the age of 40. And we had a median follow-up of over 5 years. Mm-hmm. So and we were able to have able to break it down as to decade age, and there's certainly a big difference in those under 40. And with her, I would say in our paper, she would have had approximately a 38% local regional recurrence rate without radiation, reduced to about 19% with radiation at 10 years. So that would be significantly higher than what's from the literature. But obviously this is non-randomized data, and so it has its own limitations, but it is certainly interesting.
Mm-hmm. And age is obviously a predictor of local recurrence for these women with breast-conserving surgery. So Megan, you're up. So this is our second case that we're going to start presenting.
Okay. So this is a patient. She's a 74-year-old female who underwent routine screening mammogram, was noted to have an oval mass that measured 6 millimeters in the middle region of her right lower inner quadrant at 5 o'clock. On ultrasound, it was visualized, and it was about 5 by 3 by 2 millimeters oval hypoechoic, 4 centimeters from the nipple. So here you can see it on mammogram. Let's see if it's this oval little mass right there, and it corresponds to this, and this is what they found on ultrasound. So she underwent an ultrasound-guided biopsy, and it was found to be atypical ductal hyperplasia bordering on low-grade DCIS with a mucinous component. And this is example of her pathology. Sorry, this red dot is marking. So here you can see the low-grade DCIS here, and then the mucin that's next to it.
So Megan, can you give us a rough number of the percentage of cases that are ADH on a core biopsy that are upstage to cancer?
So it varies in the textbooks of what you read, but anywhere from 20 to 30% of ADH can be upgraded, depending, and it can be either DCIS or invasive.
So yeah, most of the latest studies show a lower number than that. So usually we're still quoting less than 20%, so 15 to 18% in some of those studies. Another question for you is, at your institution, do you surgically excise all papillomas? Because this is actually one of those controversies. What are you guys doing with papillomas? Do you know?
It's surgeon dependent, but usually if there's any atypia associated with the papilloma, they will excise them. If there's no atypia and the radiologist used a vacuum assist biopsy, a lot of times then they will just observe them.
Yeah, so we're just open for enrollment, the TBCRC papilloma study that looks at flat epithelial atypia here and papillomas and whether surgical excision and upgrade rates. So I think it'll be an interesting study to keep an eye out for because it's going to give more current, modern numbers than what we sort of see in the literature for older studies. Okay, go ahead.
And so other pertinent history, you can see her gynecological history here. She's G8, P8, otherwise had early menarche, early first pregnancy, had early surgical menopause, and really no other major risk factors. She has standard medical problems for our Parkland patient population, and then has really no family history significant for breast or ovarian cancer, but did have a son with prostate cancer. So she underwent a surgical excision with a right wire localized partial mastectomy. And her final path did show ductal carcinoma site 2 grade 1. It was 5 millimeters in maximum distance, ER/PR positive. The margins were greater than 6 millimeters, and then she did have some also associated atypical ductal hyperplasia. So this is her pathology here. Yep. Sorry.
Yeah, sorry. Does size of your margin matter for DCIS here? Do you try to go really wide? Can you tell us a little bit about that?
No, we usually use just the 2 millimeter margins, and this was just what we had attained. If you're looking at the Van Nuys prognostic index, then you use that there. That's kind of why I included it in the presentation.
Okay. And so what would you tell this patient with low-grade DCIS is her risk of ipsilateral breast tumor recurrence if she foregoes radiation?
So if you look at the Van Nuys prognostic index, she is grade 1. She has the between 1 to 9 millimeter margin. low or small tumor size at 5 millimeters, and her age is greater than 60. So she has about, based on that, about a 1% risk of recurrence. It's very low for her. But again, that's just based on that prognostic index.
So what about the ECOG 5194 study with observation for low-grade DCIS? What did they quote for the low-grade group? A little bit higher than that. Anyone else? So according to that study, which took and divided patients into low grade, which included low risk, which included low grade and intermediate risk, and versus your high grade group, the 5 and 7 years were 6% and 10%, so not very high, especially as this patient is significantly older. So I think that it's her risk of another occurrence would be very low with this low grade. Okay, go ahead.
And so she was seen by a radiation oncologist and medical oncologist, and she elected for observation for the radiation instead of actual radiation, and then tamoxifen for 5 years.
So would an aromatase inhibitor be wrong? What do you think about that data that just came out as an alternative option to tamoxifen? Is it better? Is it worse than tamoxifen?
I think it's similar. The follow-up for the tamoxifen study is longer, but it's similar. And I think that's why our medical oncologist voted for the tamoxifen instead.
So just as a little, just newer data, so ASCO last June, the NSABP B35 study was reported, which looked at a trial of 3,104 postmenopausal women with hormone receptor positive DCIS randomized to tamoxifen or anastrozole for 5 years. And all patients had lumpectomy and RT, so this was, including all comers and with standard of treatment of lumpectomy and radiation. So at a median follow-up of 8.6 years in this study, the anastrozole had a significantly improved breast cancer-free survival, and they saw a reduction in ipsilateral breast tumor recurrences. So currently, according to newer data, an aromatase inhibitor may be reasonable to use and probably better. It also has a better side effect profile than tamoxifen in a postmenopausal patient, where you would have side effects like potential endometrial cancer or blood clots and other issues. So I think that it's reasonable to use endocrine therapy, especially as this patient is electing for observation. But there is some newer data that shows aromatase inhibitors are a little bit better. Go ahead.
That is my last slide.
Okay, great. So we're going to go ahead and turn over the discussion to Dr. Cody, and then we'll just do a couple more questions on this.
Well, this is clearly the other end of the spectrum compared to our first case. This is a postmenopausal lady, fatty radiolucent breast, clearly does not need an MRI to evaluate the lesion. She has ADH bordering on DCIS. This is always a dilemma. Do we treat it as ADH or do we treat it as DCIS? I think it can help to get a second pathology opinion, but I think whether it's ADH or DCIS, this is clearly a very low risk lesion. What you will all learn in practice is that there are certain consulting pathologists who tend to call these benign, and there are certain who tend to call them malignant. So with experience, you'll learn how to pick your pathologist. Clearly, this lady is a great candidate for breast conservation. Just off the top of my head, I wouldn't be at all enthused about giving her radiation. So I'm glad your radiation oncologist agreed. She is a good candidate for tamoxifen, but I think if she had trouble with tamoxifen, I wouldn't have a problem with her not taking that either. The new data on aromatase inhibitors, I think, are very good data. But I think AIs certainly have a side effect profile of their own, And you've probably, if you've spent much time in clinic, heard patients complaining about the side effects of their AIs as well as tamoxifen. So this, this is always a little bit of a trial and error, finding out which hormonal agent the patient agrees with best. For imaging going forward, I think this lady really just needs mammography. It doesn't look like her breast tissue is dense, so I don't think a sonogram is adding value there. A word about the Van Nuys prognostic index. This is something that it has some limitations for us. I think Mel Silverstein gets a lot of credit for coming up with this because he was the first that really collected a large database of patients with DCIS back in an era when no one really knew what to do for DCIS. And he really led the way in trying to come up with a model prognosticating for local recurrence and the extent of treatment. There are some limitations to it. It was retrospective. There wasn't a consistent prospectively applied algorithm for giving patients radiation. The follow-up is actually limited. Their 10-year results have been reported, but the follow-up is limited. He did very careful pathologic sectioning of all his specimens, such that they were able to accurately estimate tumor size. I think if you go into any of your own DCIS databases and start looking at path reports, it's very hard to estimate the size on many DCISs. Our pathologists do their best with this, but as you know, DCIS can be scattered, it can be discontiguous. Measurement of size, which was a key component of the Van Nuys index, is problematic for lots of us. And I think in general it's been supplanted by the prospective randomized trials, of which we have a lot of data with very good long-term follow-up. So these days I'm much more influenced by what we have from the prospective randomized trials than I am from the Van Nuys data. But I think, having said that, Mel certainly gets a lot of credit for having been the first to come up with this, and on his own PC, collect and analyze the data with some very high-level publications resulting from it. So I don't mean to detract from his effort at all, but I'd go with the randomized trials these days. I don't have much else to add for this lady. I expect she's going to do very well, and her likelihood of ever dying from breast cancer is probably way under the averages that we quote for DCIS.
Okay. Thank you, Dr. Cody. So I just have two other things to bring up that are sort of current and new, one of which we talked a little bit about in the first case, but just to kind of review. And I'd also like to find out if any of you who are on this call are enrolling any patients to this. So one thing to discuss is the CALGB 40903 Alliance study. And what this study is doing is enrolling patients with postmenopausal DCIS ER positive, sort of this patient, after they've had a biopsy and certain imaging, and then they do letrozole for 3 months, they do a reassessment, and then letrozole again for another 3 months with a surgical correlation with excision before and after the treatment. So I was just curious to see if anyone out there is enrolling patients to this study and what their experience is, and with patients wanting to do this or not wanting to do this. So I'll open it up. It always takes a couple minutes to unmute your mic, so if you want to go ahead and chime in or send me a question through the chat. So while we're waiting for that, there is a question that came up, is that do we routinely use post-lumpectomy mammography in DCIS to evaluate for residual calcifications? I think it's always important to look at your pre-op mammogram to see if there were a lot of calcifications, and also obviously your specimen radiograph. But the traditional answer, and without just small little caveats, is yes. If you've had calcifications that were significant pre-lumpectomy, then especially when margins are unclear, post-lumpectomy is helpful for targeting.
Let me just add that I personally hate post-excision mammograms. This is my own outlier opinion. I'm not speaking for the breast service here. But I think these can cause a lot of problems. I think in a patient who needs a re-excision for a close or positive margin, you absolutely want to do this if the DCIS presented as calcifications. You want to loc whatever is seen on the post-excision mammogram, and I think that's an absolute indication to do it. A patient with a minimal extent of calcifications, I don't think needs it. Patients with scattered benign calcifications throughout the breast can be problematic because after your excision, those benign calcifications often move closer to the excision site. And then you have the dilemma of seeing residual calcifications, having to go back and do a core biopsy or consider another surgery. So I think there are indications to do it, but I would just like to make the case that I don't think it should be done routinely because it often delays moving ahead with treatment. You always do it when you're going back for a positive margin. But that's my only absolute on the post-excision mammo.
Yeah, so we got a couple messages coming in on the question about the CALGB. One is that from Rochelle and Vanderbilt, we're not enrolling but have done similar plans on patients. And then from Mary Kay, our research team has informed us this is close to accrual on January 25th. So I think that is one of the things. We're not open here, so it might be that we're not moving forward. But it is an interesting approach to consider for all these patients, especially if you're going to consider foregoing radiation and giving them hormonal therapy. So, and then the other question I have before I just open up for general questions to sort of round out this evening is this whole idea of the LORIS trial. So the LORIS trial in the UK is enrolling patients with low intermediate grade DCIS to routine surgery versus surveillance. And one of the premises of this is that in the surveillance arm, there won't be any endocrine therapy or radiation or any surgery. So, and then the other arm of the study is just surgical treatment as indicated. So it'll be interesting to see what happens. It's almost like a natural history experiment for what happens with untreated. One of the good things about what they're doing, at least, is the biopsies have to be 11 gauge, but there is no role for MRIs that's mandated or interval evaluations beyond routine mammography. So, I mean, I can think of a couple of patients that I have seen in my office through the years that would love this trial because they don't want anything done for their DCIS. But then the other side of that spectrum is the other patients that come in that have a lot less than this who want more done. So I think that it'll be interesting to see what happens with this trial. Dr. Cody?
Yeah, all of our literature to date on the biologic potential of untreated DCIS is patients where they went back retrospectively and found DCIS in specimens originally reported to be benign. So there's a significant bias there, and we don't, to my knowledge, have a good current era study that's really asking the natural history question. So I think this will be a very interesting study to keep our eyes on, and will give us some leads as to whether there is a group of patients who can be safely observed.
Great. So in the last few minutes or so, I'm going to open up, so please go ahead and either go to your mics and ask us questions or use the chat, and I'll go ahead and read them.
Hello?
Yes?
Jennifer again. I was wondering, is there any other study open right now for DCIS that we could enroll our patients in?
No. I mean, from what I found, these are the basic ones that are, the Alliance trial is probably the one that's actually accruing.
Shelley Wong is opening this.
Go ahead.
Oh, I don't know the details.
Okay. So no, we're talking that among ourselves that Dr. Wang at Duke is looking at starting another study recently. Our fellow here is going to be joining her in July as a new attending. Any other questions?
Let me ask you, as a group, do you think HER2 status matters in DCIS? I'd welcome your input because I'm not sure I know the answer to this.
Neither do I. Okay.
Yeah.
Any other questions? Someone answered.
This is Rachel.
Yeah, go
at
ahead.
Vanderbilt. As far as HER2 status, my question was, our pathologists seem to have a difficult time really assessing HER2 status on DCIS. Do you all find that with your pathologists as well? And that's why I wonder what the role of HER2 is with DCIS, because I wonder if we can reliably assess HER2 status.
So we currently don't, just like someone say, stain for HER2 for DCIS. A lot of the DCIS does overexpress the HER2 status, so we haven't been using it for any kind of staining or clinical type of treatment decisions at all. And I don't think that currently outside of some trials there's any role for clinically using any HER2 associated with DCIS for treatment decisions. One of the things that's interesting is as we're looking at ongoing studies and research and laboratory to clinical aspects of this, it'll be interesting to see what we do going forward with this and whether there's some vaccines or things that we can target for these special type of research questions.
Let me also ask the group, what about the recurrence score for DCIS? And, Oncotype DX has certainly been a game changer for us for invasive disease. But what about the recurrence score for DCIS? Is this something you're using, and what do you think of it?
So just to give you background, DCIS scores 7 cancer-related genes and 5 reference genes in the study, in the test, and they were validated with that subset of patients that were on the ECOG 5194 study. So what they broke it down in low, intermediate, high, very similar to what is seen for oncotype scores. And low scores, 10% 10-year risk with an invasive risk of 3.7. The problem with the scoring is that the intermediate and high grade are very similar, so 26.7% for intermediate versus 25.9% for 10-year risk. So the problem that we have, and we currently don't use it here at Memorial, is sort of what to do with this, because even in the lowest category, you're still having a 10% risk. So to make a decision outside of what we know from a clinical aspect and forego radiation has been a little bit difficult for us to adopt. So it looks like from the answers, Mary Kay, we don't regularly use it at Cleveland Clinic, Akron General. So I don't know, it's one of those kind of things that there are some variations. So Irene Wapner, hi Irene, how are you? So the only way you can chime in is if you call in, because otherwise hard to do, but if you go ahead and type us in a message, I can go ahead and read it. So Amelia D, at the University of Pittsburgh, we do not use the Oncotype DCIS recurrence score. So, okay, Irene Wapner, B43 studied HER2 disease, lumpectomy and RT. Okay, so Irene, do you want to give us some indication of what you, yeah, study closed, no data yet. Thank you. I didn't know that. We were like, oh, I don't think I know the data. So it'll be interesting to see. Thank you, Irene. Okay.
We were very nervous about
we were like,
we didn't know what to say.
Wonderful. Okay, so I'm going to go ahead and do the wrap up for this. It's 6:55. We're supposed to schedule the end of this at 7. I think these webinars are wonderful. I want to thank Dr. Cody for being our discussant today, as well as for Anna Oliveris for arranging all of this, and for all of you to take the time out to participate with us here tonight. I think these are really important to kind of come up with just interactive, collective discussions with all the SSO fellows, and we hope to do some in the future. So without anything further, I'm going to go ahead and sign off. Thank you, everyone.
Thank you, guys.
This concludes today's Society of Surgical Oncology webinar. Thank you for attending.
Thank you.
The moderator has ended the conference. Goodbye. Thank you for calling.